So hello and welcome. For those of you who are new to us, my name is Rosanne Corcoran. I'm the host of Daughterhood, the podcast, a Daughterhood Circle leader, and I was my mother's primary caregiver through her 12-year journey with vascular dementia. Daughterhood is a safe haven for caregivers like you to connect, gain knowledge, share your experiences, and most importantly, realize that your feelings are not just normal, but also valid. We understand that the system is not set up for you, and that's why we are here, ready to support you every step of the way. Some housekeeping for today. This is a special circle, so we will be recording it. I know you all have questions, and we have a number of people on with us tonight. So if you would like to leave your question in the chat, feel free to, and I will ask it for you. If you want to ask your question personally, please use the raise hand button at the bottom of your screen, and I will call on you and you can talk to the Clionskys. I ask that you try to be concise with your questions as we only have them for a limited time and want to get through as many questions as we can. So tonight, I'm so happy we have Dr. Emily and Mitchell Clionsky, a husband and wife team with a combined 70 years of professional and clinical experience in medicine and neuropsychology. They've treated over 20,000 patients in their private practice in Springfield, Massachusetts, and are frequent public speakers, podcast guests, and workshop presenters. Their most recent book, Dementia Prevention: Using Your Head to Save Your Brain, was published earlier this year. And having read it myself, I can say it is a hopeful and practical guide to taking care of your brain. You can find all of this information on their website, BrainDoc. It's also in the chat. And Dr. Emily and Mitchell Clionsky, welcome and thank you for being with us tonight.
Thank you, Roseanne. It's great to be with everybody tonight.
Happy to be here.
Happy Thursday. So, anyone want to start? Does anybody have a question on the top of their mind? Nicole, I see you thinking.
No, I am. Well, the thing that I loved most about your conversation with Roseanne on the podcast, and the thing that the myth that I try to dispel for most people is they automatically think, since my mom has Alzheimer's, I'm like pretty much guaranteed to get it. And I'm like, no, it's mostly lifestyle. And so and I think you quoted, and correct me if I'm wrong, that basically 5% of the equation is genetics and the rest is lifestyle. So I think we need to get that message out there. And so that's what I try to do.
Mm-hmm.
Go ahead.
Oh, thank you, Nicole. That's a great point. And I think that it also leads into the general message that we want to give, which is an optimistic message that says that the statistics, the data tells us that 50% of all dementias are preventable, and that even if somebody has a diagnosis of dementia, if you institute the kinds of lifestyle and health improvements that we talk about, you can slow down the rate of decline, help to keep that person functioning better, longer, extend their lifespan, help to keep them engaged with you as a real person much longer than otherwise. So even when people come in to see us, and it's pretty clear that someone's already diagnosed them with dementia, or our testing shows that they have dementia, that's just a starting point. And as I like to tell people, even though I don't play golf, I like the metaphors. You play it where it lays. Sometimes you're on the fairway, and that's great. Sometimes you're in the rough. Occasionally you're in the woods. You don't want to be in the water hazard, but you got to play it from where it lays. And that's where you're looking, because you can't look back too much. You have to look forward.
Yep, absolutely. Jane has a question. With two parents diagnosed with dementia, is it mostly lifestyle?
Well, you aren't having, there's a genetic loading there.
Yeah, there is genetic loading there, and not all dementia is the same kind of dementia. So we talk about all-cause dementia, and 1 out of 2 cases are preventable in the United States. But it's important to recognize that one parent could have had a vascular dementia, one parent could have had a frontotemporal dementia. So in either case, even though there's genetic loading, the most important thing for you to do is to fix all the things that are fixable, that are reversible, that are preventable, because we know that the factors we've identified in the book do bear on whatever kind of dementia may be present, or you may have a genetic loading for. So it's not a necessarily a more horrible picture. It's just a question of what went into their getting dementia, what their lifestyles were, what their medical risks were. It's very complicated when you take a look at what the pieces of the puzzle were for every individual. And that's kind of what happens when someone comes in to see me. I have to figure out what were all the pieces that went into producing this state of the brain in this particular person, because it's important that I tell their daughter, who's generally the person who brings them in to see me, their daughter, what really happened here, because she then is going to be the spokesperson to go out and tell the rest of the family, and also to tell the grandchildren that may be present how they can avoid these potential dementia risks in the future.
And even if there's two parents with dementia, are you going to try harder than if you only had one? Because that's the other question. Some people tell me about these horrible family histories, and they've got all this genetic loading. And the answer is, well, what are you going to do? Are you going to walk faster if you're trying to exercise? Are you going to do something different? Or are you just going to do your best?
Right. And there are so many cases, I have to tell you, when you take a look in our book, as you can see, there was a study that we actually presented to the American Academy of Neurology. When you take a look at so many of the factors that are correctable, the B12 deficiencies, the hyperhomocystinemia, the lack of oxygen when you're sleeping, the drugs that we use for urinary incontinence or to help you get sleep when you've got insomnia. There are so many things that are correctable. We really can't say for sure, unless a biopsy was done on your parent, what kind of dementia they had. So you don't even know how much of that was completely preventable. And it could have been.
And you don't just inherit their risk for dementia, you inherit their risks for other intermediate kinds of things like diabetes, for example, which is a big driver for any kind of neurological decline.
Right. High blood pressure, overweight. Overweight is just not a matter of overeating. I like to remind people about that. It's a matter of inflammation. It's a matter of the way our bodies have been taught to respond to food triggers when we're younger, and how it completely shifts the way our brains perceive and respond to different kinds of food and to satiety. So as Mitch pointed out, there's so many other inheritable factors that can impact your dementia risk. It's important to take a look at all of them. So if you haven't taken a look at the dementia prevention checklist that you can get online, you don't need to buy our book to get this, but if you haven't looked at that, go ahead and download that, because it gives you the list and it'll give you some place to actually start and take a look at what you need to be thinking about and concentrating on.
That's wonderful. I put the link in the chat for everybody to see.
Yay.
So the bottom line is, you can't just say, well, I'm going to get it because they got it. It's just
right.
not one thing. Okay. That's very helpful. Thank you. Claire, you have your hand up. Welcome. There you go.
So I wanted to come to this a little more prepared. I had read an old article, and it was about biomarkers. And it was results of studies and work done in some California university. It might have been Berkeley, I can't remember. But right now I can't put my hands on that article. And I read the article
when we want it, can we?
I know. I read the article. I probably read it twice, and it was a lot of it over my head. I just retired from the University of Maryland. I was in the biology department, and I almost asked my department chair to read it and then tell me in layperson speak, what is it talking about? He's a neurobiologist. Wow. And my question is, do you put any credence in testing for biomarkers? So what I think I understood the research to be about was that there's something in our genetic makeup, people who have dementia, who something in the blood, something to do with how things are exchanged in the brain, and that they can test now for to see if you have it, to see if you have the biomarker or not. And then if you do, what happens? So what can you tell me about biomarkers and testing?
Wow. Well, Claire, you've certainly asked a really big question. It's not a shy question by any means. And so when I get one of those, I always ask Mitch to start the answer. So Mitch, why don't you start and I'll pick up from wherever you leave off.
Well, this is a question I get asked all the time, actually.
Yeah.
And it's because there are now available blood tests for two particular markers, one of them being beta amyloid and the other one being phosphorylized tau, p-tau, T-A-U, both of which do have relationships in gross ways with some of your biological risk for having Alzheimer's type dementia. So first of all, you got to go back to the question of what types of dementia are there? Alzheimer's is not the only type of dementia. It's maybe individually by itself with no other contributions, anywhere from 20 to 30% of the true dementias. There's vascular dementia, which is equally as probable, doesn't have those markers. And there's a combination of vascular and Alzheimer's disease, which also is very important. So you end up with the two of those making up about 60%. Then you have dementias due to Parkinson's disease, dementias due to chronic traumatic brain injuries, football players, rugby players, things like that.
Huntington's,
alcohol abuse. There's a whole variety of different smaller numbers and percentages. So you're focusing here just on the pure Alzheimer's type of pathology. A couple of years ago, we used to be able to see this, and you were involved in the study actually, with being able to see how many markers or how many dots on a screen of amyloid molecules or cells. I don't know exactly what the thing was.
don't worry about it.
For the PET scans, for
Right.
positron emission tomography.
Right.
But you could sort of quantify it that way. But I really think that what they're looking at is trying to take dementia and unfortunately simplify it into being primarily Alzheimer's type of dementia, then trying to measure it with these biological markers, and then using that as the entry point for treatments that combat the buildup of beta amyloid primarily. And that's where lecanemab, which is the one currently really available medication. It's a twice a month infusion that goes in and signals for the body's own abilities to go in and attack and break up these beta amyloid plaques, and they get in the way of transmission of information. There's good and bad to this. And so part of the good is that this is a focus for treatment, but getting rid of the beta amyloid plaques has not really successfully done much. There's a couple studies, one of them which is probably the best study, that shows that maybe we're retarding the decline. None of these make it better. We're retarding the decline in dementia by about 20%. It's about 3 months out of 18 months duration. So you're at a couple months less than in decline than if you had done nothing. Problem with the studies are we don't really know how they stack up against currently available non-infusion treatments, the ones that have been out for 20 some years. They didn't do that comparison in these studies. So is it better than what we already have and have been using? We really don't know. We do know that in the studies that we did, that you can slow down progression of dementia significantly without using any of these new infusions. The second thing is we don't know what it would mean in the following 18 months because the studies only go out a year and a half.
Right. When you actually take a look, and we give you the results of this study that we presented, when you take a look and you do all the things that are reversible and correctable, and you use the available drugs for Alzheimer's right now, whether regardless of the kind of dementia the person may be suspected of having, and you fix all the reversible things, you fix their obstructive sleep apnea, you fix their hyperhomocystinemia, their iron deficiency, you correct their slow heart rate, you get them off the benzodiazepines, you do all this stuff. What actually happens is after the first 6 months, the cohort that was treated like that actually improved from their baseline cognition, regardless of what their starting point was. And they stayed at that improved level for a period of 2 years, which exceeds significantly the results that we've seen out of any of the monoclonal antibody studies that have been released to date. But back to your real baseline question, Claire, which is the biomarkers. You know, you've heard things about ApoE4 alleles, and if you have one of them, it's this percentage of risk. If you've got 4 of them, it's this greater percentage of risk. And Mitch mentioned the p-tau as well as the beta amyloid, different types of markers. The reality is it doesn't make sense to just generally test everybody for those kinds of things, because right now we don't have, other than what we've laid out in the book and what research has clearly demonstrated, there is no one medication that we can give somebody early enough that will significantly reduce their risk of developing dementia or stop it where it's at. And until we come closer to that, it really doesn't make sense to identify it unless somebody really wants to participate in a randomized controlled trial for new medication, in which case that protocol of that trial of that drug is they're going to determine what biomarkers they want to look at.
Right.
So biomarkers are great. It's good for us to learn from. Is it ready for prime time? Not really. The other flip side is I wouldn't advise anybody to get even ApoE4 allele tested for, or Huntington's, or specific markers for other genetically conferred risks, unless I actually told my patient to make sure that they blinded their name when they went for the blood test, because I don't want that information even held in supposedly a secure medical knowledge area. And I don't want their children potentially to be, I don't want that even to be associated with their children. I really, I'm just very sensitive to medical data. Call me crazy, but I am.
Not crazy at all.
My job is to protect my patient and their family.
Yeah. Yeah. So what about like the 23andMe's that we see and the commercials for, you know, I'm allergic to these foods and I can take this test and it'll tell me. All of that, they can test for APOE4. So you wouldn't advise to do any of that.
I have not advised my patients to do that.
Yeah. Yeah. Okay.
And if you're actually worried about allergies or you're worried about a specific medical condition, I would get to a physician and specifically ask them to test you for allergies, because believe it or not, still the best way to do that are those really terrible little patch tests all on our arms and our back.
Yep.
It's still the best way to test for allergies.
Okay. Okay. No, that's great to know. It's great to know because it's you don't know where it goes.
No, you don't. And they make it look safe. And you know, that's what marketing is about.
Absolutely. Absolutely. And it works. Sharon's wondering, when do you get a baseline neuropsych test?
And the question is, do you ever? Here's why. The way most neuropsychological evaluations are conducted, the way I conduct them, is we do a whole battery of different kinds of tests looking at a variety of mental functions. We want to cover all the important areas. So we're looking at attention paying, we're looking at processing speed, we're looking at learning and short-term memory in 4 or 5 different ways. We're also examining language and communication, problem solving, abstract thinking, all of what we call the executive functions. We get the results from those tests and compare them against really good estimates of what someone should be able to do. How do we get that? How do we know what you should be able to do? Well, there's two ways that we do this. The first is demographically. We compare you with people your age, similar education and occupational levels. But the other way we approach this is through a reading test. And this reading test is pretty interesting. It's a pronunciation test. So we give you a list of words that you can't sound out. They're called phonetically irregular words. They're sight words. Probably the easiest one on there is the word ACHE. Now you look at that, and you're going to say ache, because that's what you've been able to say ever since you're a little kid. Isle is another really good one, AISLE. Well, it turns out they get more and more difficult. And your ability to read these words and pronounce them correctly is also a marker for your background level. So we find that by combining these two, we can come up with a really accurate idea for 99% of the people. I mean, there's outliers. There's people who are just, super geniuses, and we're going to underestimate their background level. But by and large, we're able to hone in on what you should do. We can compare the scores and generate a profile to see how consistent your current functioning is with your background. So that actually has pretty much the same level of comparative reliability as giving you the test and then coming back 5 years, 10 years later if you have a concern. So usually, and it isn't actually covered by insurance either. So if someone calls up and says, I want to come in for a baseline and here's my Medicare number, we say Medicare does not consider this to be a medically necessary kind of thing. We don't actually encourage it. I mean, if you're really hard pressed, you're going to put our feet to the fire, we'll do it. You're going to have to pay for it out of pocket. But it's not going to give you any more advantage than when you're concerned about things coming in then. We'll see how you stack up at that point.
Okay.
Now, if your question has to do with, gee, I used to be able to remember everything I wanted at the grocery store without having to write it down. And for the last 6 months, I've only remembered 3 out of 10 things. And I'm having little spats with my spouse or with my loved ones because they say that they told me things and now I can't remember that they said them, and we're getting into spats about that. Or if you feel like you're slipping, that's a cause for going in for neuropsych testing, although you may be just the worried well, or you may be at a point medically where there is something to take a look at that may show up on neuropsych testing. So it depends on what the situation is. But just as healthy 45, 55-year-old woman, just to get a baseline, nah.
Not going to help you. Well, let me go back. Actually, I saw Claire come up with a question, actually the link to that article. This is the kind of article that we see probably 4 or 5 of every week. And there's some tests that you can take. It's usually pretty esoteric that's going to predict risk of, Alzheimer's or other type of dementia some years down the road. When we started looking at how do we bring in all the different research on dementia for our book, one of the rules we made was we were looking for confirmed science, because otherwise we would drive ourselves crazy. Emily, look at this. What do you think about this? Here's a mouse study here, and here's one over here, and you can.
And we've cured millions of mice
Yeah,
already.
Right. Yep.
And there's all kinds of things that are out there that the follow-up studies are never done.
Right.
And so even
Or they fall flat.
right, and they never get published because of that in many cases. So you don't want to be at the forefront of some of these kinds of things because you want them to withstand somewhat the test of time and being replicated, being applied. And a lot of the stuff that's the clickbait on the internet is stuff that's at best 4 to 5 years from any really practical kind of application.
When
Can I do a follow-up to my question, Roseanne? Is it okay for me to?
Sure.
So just, I mean, I would think maybe other people are interested because I'm assuming almost everybody's on this call because a parent or both parents have had dementia. So, you know, my mom recently passed, but um I started taking care of her about 5 years ago, and once she was closer to me and I was seeing what was going on, I baseline tested her like 3 years ago. So I was able to kind of track where she was at. But everything I've read says, you know, you probably, before you're diagnosed, you're probably like 10 years before you're diagnosed is probably when it all started, right?
And it depends on the dementia, but it can actually even be longer than that, but go ahead.
Yeah, so as somebody who's kind of like, as I say, in my final phase of life, I mean, mom was only 21 years older than me. And if I am gonna have it, like if I think there's a chance I'm gonna have it, I'm gonna plan differently. Right, like what you know, like how do you trying to plan the best, and I do everything, you know, I haven't read your book, but live a very healthy lifestyle. And so I'm sorry, my mom's cat is being introduced to my cat since my mom just passed, and
Okay.
so I have lots of cats crying in the background. My apologies, but for my own self-planning, that is why I'm bringing that up. And so I guess my question is, are you that confident that if you do all those things, if you do all the things and you live basically a healthy lifestyle, you're going to do as much as you possibly can and not to really worry about or try and plan for, you know, do I spend that 300,000 on long-term care insurance, right? That's kind of the gist of why I was asking the question.
And that's a very good and legitimate concern. I'm so sorry that you've just lost your mom. My heart goes out to you on that. And trying to get the two cats together. It's it is the very, very best bet that you've got if you really do all the reversible, controllable things that you can, that we list in that dementia prevention checklist, really and truly. And I can say that with confidence because I was working with and do work with patients who are at all different stages of dementia and who are healthy in some cases. And we have been able to significantly impact their lives. And it's not just happened in our practice, it's really what the data across the world in very large, well done studies have demonstrated. So, can we say with any assurance that you shouldn't spend your $300,000 on the long-term care insurance? Nobody can give you that guarantee. There's no guarantee that we have in life for anything, but it's probably the very best that we can possibly tell you.
Let
Go
me
ahead.
jump in here because there's a couple of points I think are related to that. I agree with you. I also know that using currently existing medications, what they call the cholinesterase inhibitors and memantine, that people stay stable at a very long. I've had people in my practice 15 years they've been coming
And
back.
that's what I was about to say. I've had patients stable for 10 and 15 years.
So people try to plan, well, when's it going to get bad? When am I going to die? When am I going to need to go into a nursing home? I say, well, you may never. I mean, you will die probably, but
Well, high likelihood, yes.
Yeah, but are you going to need to have long-term care insurance? I don't think so. To tell you something else, the people I see who've bought long-term care insurance, unless it was a very long time ago, oftentimes have to be nearly dead in order to be able to get the benefits
Right.
from it. The policies that are being written these days, if the last 5 years, are so limited in terms of their coverage, require so much of a deterioration that they come in and say, but you say she's got moderate dementia and she can't do this and she can't do that, but they won't allow me to use my insurance because she can still bathe herself.
Which is utter craziness because you really need the long-term care insurance, not just when somebody can't complete their basic activities of daily living, but often when independent activities of daily living are compromised. So I agree completely with your point.
So that gets back to my original question, like, how do you know when you're supposed to go on meds, like if you don't baseline test? So,
Because if you go and get tested, they'll compare it with your expected level. I mean, you can get baseline tested if you want. I don't want to discourage you from that. And with every repeat evaluation, there is a certain amount of variability in scores that is normal. That doesn't indicate a change. And so that's also what we often see is that someone will have had an early baseline testing. We're seeing them 5 or 10 years later. Their scores are still within the margin of error of what they had before. They may subjectively, however, feel like things have really gone downhill. They may just not show up that way in a structured objective test situation.
There have been plenty of people who come in and they have not had significantly bad neuropsych testing scores. They've been marginally mild cognitive impairment. So far, unless you're working with a doctor like me who does a lot of dementia work and knows the literature well, most doctors will not start those patients on dementia-sparing medications.
that's right, that's what happened with my mom.
And that's how we managed to get the results that we did, because those drugs are effective at an earlier stage than what they were ever tried at. And they didn't meet the criteria. For instance, memantine never met the criteria to be used according to the FDA for mild dementia. Well, the reality is it works just beautifully at MCI when used with a cholinesterase inhibitor. But the bottom line is if you've got a feeling like there may be something wrong, go get the baseline neuropsych testing. If you're completely normal, even I would have a hard time starting you on medication, but I would not have a hard time saying, go get a sleep study immediately. And if you don't absolutely have an apnea hypopnea index of 0 or 1 or 2, please, let's get you on continuous positive airway pressure. Let's check your homocysteine level. If it's not under 10, let's get it there. Let's get your cholesterol, get your LDL down to 70. Let's get your methylmalonic acid level down to 250. Let's get your vitamin D, 25-OH, up to 70. So there's a whole body of actions that can be brought to bear before you're ever put on medication. And I'm sorry that your mom was not put on medication when she was in the early stages, because it probably would have made a difference.
That's great. Thank you.
You're
Great
welcome.
explanation. Another question. Can dementia also be a result of environment and lack of intellectual stimulation?
Absolutely. Absolutely. And we know that from so many studies at this point, from a great, breathing air perspective, from the water that we drink perspective, we know that pollution now, by the time the next great big research studies come out, that they will probably incorporate pollution as one of the great reversible factors involved in dementia. There have been large significant studies that have empirically demonstrated that pollution in our environment is a cause of dementia and cognitive decline, not just as we age, but even as in our younger years. And lack of stimulation intellectually is certainly important in later life, middle age, and as we age in through our 60s, 70s, 80s, and 90s. But we know that education and educational stimulation in a structured manner can be protective. It's one of the protective factors that we have against developing dementia. So that I don't advise people going to med school like I did at 42 years old, but if there's a way that you can really continue to take on a structured educational challenge in through midlife, that would be helpful, and encourage the grandchildren and all the young people we know to stay in school as long as possible, and to consider, structured education.
The other thing about social or intellectual stimulation is you got to ask the baseline question, why is this person understimulated? Is it simply a function of geography? You know, they decided they were going to live out in a very rural area, don't drive anymore, so that they're not really interacting with people? Or is their lack of stimulation the result of other factors that you can intervene with? Maybe they're depressed. And of course, that gets into a round robin kind of thing where you're depressed, you don't interact, you don't get stimulated, you get more depressed. And getting people out and interacting becomes a major part of the intervention that we always do with people, because we don't want them just spending their time sitting in front of the TV set all day. That's a bad way to spend your life anyway. It's even worse if you have the makings of dementia, because it doesn't give you the stimulation you need.
Now, there are some forms of dementia that the very earliest stages may be heralded by or accompanied by a change in personality, where someone who has been very talkative and very social and the life of the party, around the dinner table, all of a sudden doesn't talk as much, doesn't volunteer as much, doesn't seem as active as much as they used to. And that can herald a frontotemporal dementia just as much as it can herald a vascular dementia. So it depends on that social isolation or the lack of stimulation. Is the lack of stimulation coming from the dementia, coming from the social emotional environment in which they find themselves? Is it financial limitation? Is it imposed from the exterior because they're living in a remote area where they don't have access to other people easily? What's really the cause of the problem?
Wow. So again, it goes back to, it's not just one thing.
Right. It's, the bottom line in life is generally it's not one thing
No,
at all.
at all. Yeah. For anything.
Which is both good news and bad news. I mean, it
Right.
makes the whole question more complicated,
Right.
because now you have to factor in a lot of things. On the other hand, it means that there are opportunities to intervene in a variety of directions.
Right.
And so when you can find stuff that needs to be fine-tuned or tuned up, it actually provides you with approaches that you can take to treatment if you approach it that way. So, it can be a good thing to be complex.
Fascinating. Absolutely fascinating. Mikhail, that was your question? I saw your hand up. Was that just as a, okay, great. Okay.
Yeah, my parents are both, and it's very odd because my father, he is also quadriplegic, but his it didn't seem as though he had dementia initially, when he had the accident that paralyzed him. But then progressively, as now that he's immobile, and my mother actually was the first one who started showing. She's actually very mobile and she's very functional, but she was the one who first started showing the signs of forgetful. It was like forgetfulness, and that started happening maybe 6 years ago, before my father even had his accident. And then my father, as he's sort of been immobile, and he's been like, I find that it's almost like because he's been interacting with my mom most of the time, that his cognizance also started to decline as a result of that. So that was where my question was. That was sort of like the crux of why I asked if it could be an environmental thing, because I just noticed that it was the interplay between my parents, one whom initially started showing signs of dementia, and because my father also didn't have enough, I guess, continued intellectual stimulation to keep his mind active, his mind started to decline as well.
Sure.
So
okay.
Still may have been other factors there. When somebody is paraplegic, they are not able to get much exercise in most cases. There may be other kinds of medical conditions. When people are paraplegic, oftentimes they gain weight because there's not a lot to do except sit and eat. So then you start getting into secondary type 2 diabetes and all kinds of other things. And again, there's probably not one thing. It's not just the environment. It's probably the confluence a variety of things.
And it depends on what type of accident was involved, and I'm not asking you to divulge that, but certainly trauma, particularly if it rendered somebody to some degree of immobility, will have an effect, obviously, on their brain. So you're looking at probably an effect of the accident as well.
Thank you. Okay. Vicky, her mom is 88, post CVA, either after her 2021 stroke and maybe before. She's completely lost her smell and taste, and to odor. Never had COVID. Are there dietetic resources for optimizing diet when there's such a loss of taste and smell?
Wow, that's a very good and hard question. Because when our taste and our smell, our taste particularly, is not just about smell, it's also about texture
Mhm.
and picking up the different components that make up the taste. So in fact, this is such a fascinating topic. The New England Journal of Medicine just published 2 weeks ago what is probably the best explanation of taste I have ever seen in my entire life. And if we can, I'm gonna give you the link so that you can get it out to them, and they can, if you want, you can post it on your website.
Yeah, that would be
But
great.
the bottom line is, when that kind of a loss of taste and smell occurs, generally there's nothing that can be done about it. And so you really just have to make sure that the person's getting enough nutrition in, use supplements if need be, encouragement, really watch what they tend to prefer when they are willing to eat. If need be, schedule their eating, because when we lose our drive to eat, our appetite to eat, which is being signaled to some degree by those taste sensors that are on our tongue and in our nose, when that's disconnected, boy, it's really difficult to keep the appropriate nutrition in somebody, particularly an 88-year-old.
Mhm.
Let me
I
jump
kind
in,
of
because loss of smell and loss of taste is something I see as well, but there's a couple things that people do that help them to stay connected with the eating process. One of them is to vary texture.
Right.
So you take something and also usually people could still taste some things that are salty or sweet or peppery. So you start supplementing, you take the sandwich and you throw some potato chips into it. And now you have something that's got a couple textures as well as some saltiness to it. Or people vary the temperature and they like to eat things that, so they like not so much the taste of ice cream, but the fact that it's cold and smooth.
Right. So
Yes.
you're going to actually, what I often advise is actually keep a diary of what their reactions are to the different textures and the temperatures and the feeding time as well. And the amount that you give them, or you make available. So it really requires good observation skills. But I really like that.
But it's the frontal lobes, which you're really talking about here, because that's what governs a lot of the smell and taste. And that happens with strokes, happens with head injuries. It's long before COVID. It was the neurological stuff that were oftentimes some of the first indicators that somebody was developing dementia.
And surprisingly, so much of what happens right at our taste buds triggers what happens in our gut and how we process food in our gut. So while Mitch talks about it being a frontal lobe problem, it is to some degree, but the rest of the stimulation to eat that is coming from that brain gut continuum is not happening. So it's a very complex issue.
It's also sometimes isn't loss of smell an early indicator of Parkinson's as well?
Yes, it's actually a very sensitive one. And not just Parkinson's, and it can also happen in Alzheimer's
And
disease.
Alzheimer's. Yep. Yep. Wow. It's fascinating. I don't know. It's fascinating. Evelyn has said 3 of my mom's family members had some form of dementia. They used those old, heavy aluminum cooking pots on a daily basis. For a while, they said aluminum caused dementia or Alzheimer's. Is that still believed to be the case?
No.
No,
Okay.
That was a real popular thing back in the 1980s. And in
Okay.
fact, a lot of the aluminum cookware manufacturers lost a lot of money back then because everyone freaked out and stopped using it. It was based
Right.
on the fact that when you do autopsies of people with dementia, you see increased levels of aluminum in their brains.
and not just aluminum. You see increased levels of iron, you see increased levels of all kinds of things in the brain. But they picked on aluminum.
Right, because they also found that even people that didn't have Alzheimer's, that when they died, their brains would give off more aluminum. So
Wow.
it pretty much got discredited, but that was a big thing for a while. We don't believe that anymore. So go
That-
back to your.
It's not that we don't believe it because we just don't feel like believing it. We
Right.
don't believe it because there is no science to support it.
There you go. Okay. We love science. Okay.
Yes, we do.
We do. Jane said, my mother's dementia meds were stopped because of intractable nausea and vomiting. Is this a
Oh, I'm
common side effect
sorry
of
to
these
hear that.
drugs? Yeah. Is that common? Is that a common side effect?
I hate to say this, but it can be a common side effect, and there's so many fingers to be pointed in so many different directions. So let me tell you what I figured out in my practice was that when I started patients on dementia medications, the very first thing that I would do would be check an overnight pulse oximetry. That is a simple little thing. It looks like a clothespin, a plastic clothespin, and it is a quick way of checking the oxygen level and the heart rate overnight. Though that data is recorded and it can come back to the doctor within a matter of 2 to 3 days. And you look at that before you start dementia medications because it tells you what the heart rate is. The one type of dementia medications that are very important are called acetylcholinesterase inhibitors. For instance, Aricept, otherwise known as donepezil, Exelon, galantamine. That class of medications can actually lower the heart rate. So as we age, our hearts can develop irregular heart rates anyway. And when we sleep, our heart rate slows down. The normal heart rate is between 60 to 100. So it would not be uncommon for someone's heart rate to drop below 60 when they're sleeping, particularly if they're older. And if they have high blood pressure and they've been put on metoprolol or Coreg or Diovan or one of the other blood pressure control medications, that may affect their heart rate as well and slow it down even further. So here they are. They develop a dementia that deserves, or a cognitive impairment that deserves dementia treatment. And unless you check the oxygen and the heart rate level first, you run the risk of lowering their heart rate even more in the middle of the night.
Right.
This can produce some changes in their body. In addition to stroking them out, it can cause changes in their system overall. So that's one thing that you do to start with. So before you even start the acetylcholinesterase inhibitor, if you start Namenda or memantine first, before you start an acetylcholinesterase inhibitor, it has been proven in very large studies that have involved 60,000 people on very high doses of Aricept at 23 milligrams. That's the highest dose that you can go on Aricept. If you start the memantine first, it prevents the development of nausea and vomiting. in someone. They may still develop nausea and vomiting, but what you need to do is start the memantine. It started low, you titrate up the dose, and once the dose is at the maximum that you can keep them on with memantine, keeping in mind their kidney function, you then can start more safely an acetylcholinesterase inhibitor, so long as they don't drop their heart rate at night when they sleep. And you start that at the lowest dose possible. And you don't give it at night. You give it in the morning. Right now, the way the label is written for prescription is that doctors are told that they should prescribe the acetylcholinesterase at night. That alters REM sleep. And also at nighttime, they're giving it on essentially what's an empty stomach. It's a very difficult drug. So if you give it to them in the morning after they have eaten, and once they're on a stable dose of memantine, you run a much better chance of not having that person develop nausea or vomiting or diarrhea. That was a very long answer, but that's the really right answer.
I went into oxygen and everything. I don't know where you're going.
Well, I went into the oxygen more because of the heart rate.
Oh, okay. Well, look, the other thing is, if they haven't tried the rivastigmine transdermal patch, that's also a reasonable approach to doing that because it avoids some of the initial gastric upset.
But you still need
Not
the
all of it.
you still need the memantine first.
Yeah.
Great answer. Jane, I hope that's helpful. Great answer.
And by the way, I have challenged, people have been, I mean, obviously, with the thousands of patients that I've treated, I have had patients who've come in and they are like, oh, no, I don't want that stuff. That made me violently ill.
Mhm.
So the real negotiation is to convince them that you don't want to do anything to harm them and that you're going to start with the memantine at low dose and let's see how that goes. And when they don't develop a bad reaction to the memantine, then you start the baby dose of Aricept or the Exelon patch after that. And it's much smoother going. I have had patients, probably only under 10 in the tens of thousands of patients I've put on these meds, who actually lost weight on Aricept. And unfortunately, they're not the folks who could have afforded a 10-pound weight loss.
Mhm.
And those are really the only people I ever had to take off of it. They were teeny weeny little women to start with.
Wow. I have a follow-up here. Joelle's telling me that her mother's on memantine twice a day and night. So it should only be during the day?
Memantine can be given twice a day, or there is now a once a day extended release option that is more expensive. So it depends on really what her drug plan allows her.
Right.
So it really should, again, if she's on it once a day or twice a day, it may be because they're trying to figure out what her maximum dose should be.
Mhm.
That may be a factor, or it may be what the drug plan allows.
Okay. I know we're up against it. I have a few more questions. Is that okay?
It is for
Good?
us.
You're good? Okay. Okay.
Yeah.
Aisha, you have your hand up. See where she went. Aisha,
We lost her.
we lost her.
Oh,
All right, we'll come back
No,
to
I'm
Aisha.
I'm
Oh,
here.
there she is.
I'm
There she
here.
there she is.
Sorry. I haven't read your book. I am so sorry, but thank you for your time today. And I'm starting to go through the checklist and some of the items in your website. My question is, what's the role of omega-3? What's your take on that for brain protection?
Brain perfect?
Protection.
Oh, for brain protection, omega-3s. You know, none of those things that you're going to ingest like that are going to make a big difference. We don't really go into very much in the book about supplements or foods that you could eat, because while everyone wants to eat their way into better brain health, we're Americans. Therefore, we are focused on diet and food preparation and food choices and when we eat and how much time in between eating. And this is a better oil than that oil and all that kind of stuff. We're talking about such a small amount of variability that it's going to, small amount of protection. So I'm sorry you haven't read the book because actually you'd see there's nothing in there about that in the book for a very good reason, which is it's just not worth focusing on. There's far more important things that you can do that'll reduce your
Right.
risk.
In some of the cardiac literature, Aisha, from about 20 years ago, there were some signals that if you could get somebody on a special formulation of omega-6 versus omega-3 fatty acid, where the DHA was much higher than the EPA, that, and you've started them on it very, very, very early, that you might be able to keep them from progressing from from mild cognitive impairment into dementia. But that was only one study, and it was done in the cardiac literature, and it was a very expensive medication that I used to have to fight with the insurance companies to get it approved for my patients. And I hate to say it, and I mean, I was really religious about it, and I did what I always do with all the medications I prescribe for my patients. I, of course, tried it myself. Well, talk about producing diarrhea. Let me tell you, it fixed that problem in a hurry. But the reality is it really did not significantly impact the bottom line, even in our large group of patients. So I discontinued that. It just was not, the cost benefit was not there.
Great. Thank you.
Sure.
I felt the same way about omegas, by the way. Evelyn. Evelyn, your
Hey,
hand. There you go.
Yes, your question 9 on your checklist is about people with diabetes. What about people who are reactive hypoglycemic? It's a blood sugar problem where everything goes lower instead of the blood sugar level going higher. Is that also problematic, or is it just not mentioned because it's not been studied as much as diabetes?
Well, we know that very low blood sugars are not good for the human brain any more than low oxygen levels are. So it really is a matter of, I would need more information about you medically, which again, I like you, but I don't want you to share publicly. So it's more a matter of figuring out what it would take to stabilize your glucose levels at a good level so that you don't have those high and low fluctuations during the day and at night. And it may be something that hasn't been suggested yet. I don't know who you're seeing for this, but that'd be something I'd get you to a dietitian for.
Okay, thank you. I don't have so much of an issue of extreme highs and lows. It's more stabilized. But it just seems that diabetes, my impression is really researched. So I never know if it's not mentioned about reactive hypoglycemia because it's just diabetes is getting all the research money, or if it's just not usually a factor.
Reactive hypo, meaning low blood sugars, are generally not the issue that we run into in terms of a major cause of cognitive impairment. If somebody is really experiencing recurrent chronic low levels of sugar that are causing mental status changes in that individual, that needs to be evaluated by an endocrinologist and stabilized.
Awesome. Thank you.
Great. Thank you very much.
Sure.
Claire said she found an article titled Placental Growth Factor as a Sensitive Biomarker for Vascular Cognitive Impairment. It was published in the Alzheimer's and Dementia Journal of the Alzheimer's Association. So her question is, what is placental growth factor and how does it relate to identifying the potential to develop vascular dementia?
You didn't tell us this was going to be the board exams. I think we were just coming for
Sorry,
a chat.
I'm sorry.
So anyway, the placenta, as we know, is that wonderful mechanism that sits between baby and mom
Mm-hmm.
when baby is still inside. And a growth factor, we have all kinds of growth factors all over us. We've got them in our eyes, our kidney, our liver, we've got them in our skin, we've got them everywhere. And as you can imagine, if you've got this person who is growing and getting bigger and bigger and bigger, there's a lot of growth going on there. So there's a lot of growth factors in the placenta. You know, my gut is that and this is truly just a gut. I have not read that article. I have not seen that. My gut tells me that anytime that you've got growth factors affect blood vessels, and the placenta is literally filled with blood vessels. Its primary purpose in life is to get blood into that growing fetus. So, would I be surprised that that has some kind of genetic implication in terms of what it might look like to people in the future, and maybe it predisposes them, you know, what the level is may indicate a propensity to develop bad cholesterol or high blood pressure or less responsive release of nitrous oxide from their blood vessels when they're under stress later in life. Who knows what it's related to, but it's certainly nothing that I'm going to worry about at this particular point with my patients.
Mhm.
I'm more worried about when pregnant women or when somebody wants to be pregnant and she gets pregnant and she's got a problem with diabetes and high blood pressure, and she was very overweight to begin with, how that's going to affect the health of that developing fetus, because we know that those conditions affect the cognition of babies. And we know that affects how those babies think when they're in the 1st grade through 5th grade. And how we think when we're young will eventually affect what our brains look like when we're much older. So if it was up to me and I had another 10 years of life left where, you know, I had nothing else to do, I'd write a dementia prevention for your baby book.
Yeah.
You keep threatening.
I keep threatening.
You're threatening. You got to do it.
That still may be in me.
Yep, you got to do it. Nicole wants to know how you feel about Dr. Rudy Tanzi's SHIELD prevention acronym and also Dr. Bredninsen's Alzheimer's reversal claim.
So, Dr. Tanzi's been, you know, he was the leader in many ways of the beta amyloid hypothesis as terms of dementia, and was very active in that. He's just down the road from us here in Boston, and was really involved in that. And then that sort of played out. I think he sort of also realized that removing beta amyloid was not necessarily going to do very much.
Right. And that was not the only thing that Rudy Tanzi has come up with. Rudy Tanzi took a look at copper. Rudy's taken a look at a few other things since the Alzheimer's, since the beta amyloid hypothesis.
Yeah. So now I'm not sure what SHIELD is, but I know that he's very much involved in anything dealing with basically what's the word I want? Inflammation. And so that's probably an acronym that's involved there.
His SHIELD is sleep at least 8 hours, handle stress, interact with others, exercise, learn new things, and eat a healthy diet. So that's his SHIELD. But
those are all good things.
It's not going to hurt you. Yeah. But Dr. Bredninsen.
So Bredninsen, we actually reviewed his book before we wrote our book.
We reviewed his book.
Yeah, we did that.
Okay. So Jane, and I think this is probably our last question. Jane wants to know, will you tell us a little more about your practice and do you participate in telehealth?
I don't participate in telehealth because I really do a physical exam on my patients that goes from top to toe. Literally, they take their shoes off when they even come in to see me because I'm looking at everything. So I don't do telehealth.
And we do people, neuropsychology is basically done in person rather than telehealth because you have a lot of materials and control over that. You know, we do things that are telehealth involved when we, give feedback sessions to people about the results of their testing, but they really have to be in our practice, in our office, in order to have what we do happen. I think telehealth is wonderful. I think that the fact that you can get consultation, the fact that you can get therapy from a distance is revolutionary,
Right.
and is a wonderful thing. But it's just not going to be. We thought about, do we put ourselves out and do consultations and things like? And I just don't think it lends itself. Maybe we're just limited in our viewpoint, but we're so busy with the patients who are coming in that the idea of I'm assuming that this is, gee, I like what you're saying. I'd love to be able to connect with you in some other way. So thank you for that. As opposed to just being a random question about whether we happen to do telehealth.
Yeah.
So I appreciate that very much.
Mhm.
But I don't think that unless it's purely from here's a dementia prevention standpoint of coaching, that it makes much sense.
Yeah.
But that's just my take on it at the moment.
Well, I tell you, I was hoping you were going to say yes also, but that's fine. We'll have to we might have to do a daughterhood road trip to your clinic in Massachusetts. We'll get a big bus and we'll just come up.
Wow, that would be exciting. You could film it and everything. It'd be great.
We'll film it. We'll film it. We'll do everything. Cause
I
I
want
have,
to go off to some resort.
oh,
And
we could do that.
That's what I'm going to do.
That's
Actually,
fine.
we've thought about trying to do something like that on a ship cruise,
Oh, there you go.
you know, but
Uh,
before we do say goodnight to
Yeah.
you all, I just want to thank you for being the daughters and the caregivers of people who need you desperately. And something I always tell my own patients, children, you've earned your angel's wings and you have my deepest respect. Thank you for your hard work.
Thank you. Thank you for that. It's been an absolute pleasure. And I wish everybody had the opportunity to talk to the both of you because aside from your knowledge, your compassion through all of this it's a gift and you don't get that many times from doctors, unfortunately. So thank you both for that because it's a gift. So, and thank you for your research and your hard work. And just so everybody knows, this recording will be on our YouTube channel in the next few days. You can also find my interview with Dr. Clionsky. We did Daughterhood, the podcast, episode 56, anywhere you listen to your podcast and on our website, daughterhood.org, under the podcast section. On Daughterhood, you'll also find the complete list of circles, the ability to sign up for our newsletter to keep you informed of daughterhood happenings, and Anne's blog and everything. Just, check us out. But I appreciate you all being here tonight, and I thank you. And I look forward to the next time we are together. So thank you. Thank you all.